Hello, my name is Clyde Yancey. I'm here at American Heart Association Scientific Sessions 2023, a truly fabulous meeting. I'm a past president of the American Heart Association. I'm professor in chief of cardiology at Northwestern University Feinberg School of Medicine in Chicago, the site for next year's AHA Scientific Sessions. I am delighted to be here with Dr. Demilade Adedinsewo, who is at the Mayo Clinic as an assistant professor governing the research enterprise, the research activity for the fellowship program there at Mayo in Jacksonville. We're delighted to talk to you because of your stunning research in artificial intelligence, and what a brilliant application. Tell us about your work.
Sure. Thank you so much, Dr. Yancey, for that introduction. So, the study that I presented today as part of the late breaking session is titled Screening for Peripartum Cardiomyopathies Using Artificial Intelligence. And what we did was we conducted a randomized clinical trial in Nigeria where we assigned pregnant and postpartum women to the intervention arm where they received AI guided screening. And we also had a control arm that received usual care. We decided on Nigeria specifically because they have the highest reported incidence of peripartum cardiomyopathies, about 1 in 100 live births. And this AI guided screening uses a digital stethoscope that is able to record a single lead ECG as well as a phonocardiogram and predicts the likelihood of left ventricular dysfunction. What we found in the study is that using AI guided screening, we were able to detect double the number of cases than we would with usual care, which was pretty amazing.
So let's unpack all of that because there's a lot of good stuff there.
Right.
So first, we found a really important clinical application for artificial intelligence. We know the technology is there, but it's a tool looking for a target. But this seems like a reasonable target. So that's the first thing, a clinical application of AI. But then targeting a very important public health concern, in fact, the maternal morbidity and mortality in the peripartum space. And we've taken this to an outside US, what some would characterize as lower or middle income country,
That is
to
correct.
deploy the technology. And the technology combines phonocardiography, a very old methodology, with electrocardiography and something called a digital stethoscope. It's probably not much listening with the human
Right.
ear, but the
Not
application
much.
of device. Whoa, that's like 4 or 5 different pieces in one. How
Right.
did you even get this idea?
Okay, so I believe that the idea started towards the end of my fellowship training, actually, when I got to meet with my now research mentor, Dr. Peter Noseworthy, who was working on the uses of artificial intelligence. And one of the models that they developed at the time was taking data from a 12 lead ECG, and they were able to use it to detect left ventricular dysfunction in an unselected patient population. And I kept thinking, because I have an interest in women's health, particularly in cardio obstetrics, that this is the population that would be ideal for screening, because there's a challenge with identifying heart failure during pregnancy, right? Because if a pregnant woman were to complain of lower extremity swelling or shortness of breath with mild exertion or even orthopnea, sometimes this is considered normal because she's pregnant and she has that gravid belly. So the diagnosis of heart failure is often missed, it's delayed, and this is associated with poor outcomes. Like, if only we could screen all pregnant women, postpartum women, for left ventricular dysfunction, because now we would have a reason to get an echocardiogram. So that was how the idea started.
So
And
this gets better and better because essentially you're taking predicate technology that uses a 12 lead ECG, applies artificial intelligence
Mhm,
to approximate a measurement ejection fraction.
that is correct.
I've seen those data, and those data are verifiable. But then you've gone into the cardio obstetric space, and you had that kind of eureka moment. Maybe this is a tool that can help us not diagnose per se, but screen, and how appropriate to have a screening tool so that you can then be more precise in the capture of information. But I've seen your data. So we're looking at the two things, phonocardiography and electrocardiography, and we're approximating ejection fractions. How well did you do for ejection fractions less than 60, and then how well did you do for ejection fractions less than 40? Some pretty striking numbers.
Yes. So for the study was designed, the primary outcome was to detect ejection fraction less than 50% because we thought that this was a clinically important threshold. But we also know that there are different thresholds, right? So there's less than 45% for detection of peripartum cardiomyopathy. There's less than 40%, which is how we will traditionally define heart failure with reduced ejection fraction. So we evaluated different cut points. For detection of EF less than 50%, the AUC of this model was 0.95. So really did a really great job. And for detection of less than 40%, which was actually what the original model was calibrated to detect, the AUC was 0.98. It had 100% sensitivity.
Let's just say that again. Your model had 100% sensitivity to detect an ejection fraction less than 40%, which is
correct.
clinically meaningful and actionable, particularly in the context of symptoms. So what did you do with that information? You already told us that you were able to double the detection rate compared to conventional care. So now with these patients identified, what were the next steps?
So we should mention that this study, the results that we're presenting is just the baseline. So participants are still in the study and follow-up is still ongoing. We intend to round up the study by February of 2024, and hopefully we will have more data on outcomes to present. But everyone who was in the intervention arm will have the screening as well as confirmatory echocardiograms were plugged to cardiovascular care, so initiating appropriate medical therapy and what they need to manage their care moving forward.
So one last question. Let's forecast this really intriguing technology from the outside US platform to the inside US platform in a very serious way. We know that women of color especially have an increased incidence of cardiovascular morbidity and mortality in the peripartum period. Is this possibly a solution, at least for screening purposes and early detection?
I think that is a fantastic question. And that was also one of the things that was at the back of our minds when we were developing this. So studies have shown that peripartum cardiomyopathy disproportionately affects Black women. Some studies have shown up to a 16-fold higher incidence of peripartum cardiomyopathy, and outcomes are also poorer among Black women, unfortunately, 5-fold higher risk of dying when they are diagnosed with peripartum cardiomyopathy. So our hope is that we can use this tool to narrow that disparity gap. Unfortunately, Black women are also diagnosed very late. They present late and outcomes are worse. Can we pick this up early if this is incorporated into routine screening? And it'll be fairly low impact for screening, just using a stethoscope at the time of a prenatal visit. And the risk associated with having a false positive is obtaining an echocardiogram, which is also safe and does not negatively impact the mother or the baby.
Let me just say on behalf of the American Heart Association, I want to thank you, but also on behalf of all of us that share a vision of lessened health inequities and the attainment of health equity. This really is important work, and we applaud what you've done and encourage you to keep going. So thank you very much.
Thank you so much, Dr. Yancey.
Great.
Thank you.
This is Clyde Yancey from AHA Scientific Sessions 2023. We're happy to be with you.